Hey guys, Dr. G here. Thanks for watching this short video. Today I have a very special guest on the show. You know, normally I post videos about exercises to treat several conditions of the spine and the neck. But today we're going to have the co-founder of the Laser Spine Institute, the medical director there. He's also very well spoken. He goes to different conferences and talks to people about innovative ways to treat neck and low back pain conditions such as herniated disc and sciatica. And the reason we're having Mr. Perry here, Dr. Perry, is because we usually teach conservative treatments at the painfreeinstitute.net website. However, there are people that are going to fail these treatments, and for that reason, we have the expert on board today. How are you doing today, Dr. Perry?
I'm doing great, Dr. G. How are you?
Pretty good, thank you. Thanks for being on here today. We have several people that have sent us a bunch of questions for you, specifically more for herniated discs and sciatica, and some people that have already gone through surgery and it failed for them. So that's where we got you on board here from the Laser Spine Institute. Tell us a little bit more about what you guys do over there.
Okay, we basically are a company that performs minimally invasive outpatient spine surgery. Our techniques are muscle sparing, which are different from conventional spine surgery. All of the surgical procedures are done in an ambulatory surgery setting. We do surgeries that basically deal with neural compressive pathology, meaning people that have pinched nerves, spinal stenosis, or compression of the spinal cord. And we also on occasion do minimally invasive stabilizations or fusions when the case requires that.
Excellent, excellent. Yeah, we have a lot of those questions come in all the time through our YouTube channel. And so you ready for the questions for people to know more information about you and what to do? Okay, so the first one coming up is a person with a herniated disc that experiences numbness going down the legs but no low back pain. Are they a surgical candidate?
Well, that's kind of a difficult question, but let me try to answer it the best I can. So numbness typically isn't the driving factor that brings people into practices for treatment. Typically, the most common symptom is pain. Pain is it's a very strong motivator. So when people have numbness but no pain, I guess it would depend on the severity of the numbness and whether it actually affects their daily activities of living, whether it affects their job. If they have numbness in their arm due to a pinched nerve, does it affect their ability to write? Does it affect their ability to hold things? Numbness in the leg, again, it can be intense, in which case if the patient has that symptom and they've had conservative care, and despite conservative care they continue to have significant symptoms related to that, then yes, potentially they can be a surgical candidate.
Okay, excellent. So you would recommend them having to go through all these conservative treatments first before going to you guys. And like you said, numbness may not be something that limits their daily activities, so they may or may not be a candidate for surgery.
Correct. Okay.
Second question we have is, at what point is surgery recommended for somebody who has a herniated disc and sciatica?
Okay. Again, like you had mentioned, and your web address here is basically geared towards conservative care. And anyone who's got a herniated disc or sciatica, again, the first thing you want to do is not jump into the operating room. You want to go to your primary care. You want to go to your chiropractic physicians, physical therapy, get the conservative care, because the vast majority of patients that have an injury to their spine, herniated disc or sciatica, their symptoms will resolve within 3 months. So my feeling is if you've got initial injury or problem related to herniated disc sciatica, get to conservative care. But there are points in which surgery may be indicated. And the two most common ones are, first, you fail conservative care. Again, that's always the first and mainstay of any treatment for a spinal condition. When that tends to fail and it's a debilitating discomfort, then surgery might be an option. The other one is if the patient has any neurological deficits related to that herniation. So what I mean by neurological deficits are patients, if you've got a herniated disc in your back and it's compressing a nerve and it's affecting the motor part of the nerve, people can have a herniated disc compressing the nerve at L4-5 and they can get a foot drop or significant weakness in their foot or leg. That is more of an indication to take a very aggressive approach to it. You want to get the conservative care, but you don't want to wait long, because a lot of times the longer that muscle it becomes weak, the longer it may take to come back. Another neurological deficit would be a patient that's got bowel or bladder dysfunction. All of a sudden they lose control of their bowel or bladder. You don't want to continue conservative care and conservative care. That is a very serious condition. It's basically the medical term for it is called Cauda Equina Syndrome, and that would require surgical evaluation immediately.
Right. Yeah, I do have a video on Cauda Equina Syndrome, and I mentioned in that they have to go to the emergency room for that one.
Yep. Okay,
excellent. Thanks for your answer there. Number 3, can someone who's had a spinal fusion still be helped?
Yes, they can. Approximately 30% of the patients that we do surgery on here at Laser Spine Institute have already had a failed surgery. So we do see a lot of people that continue to have problems after they've already had an open procedure. And it depends on the patient's condition and to the source or cause of the patient's continued pain, basically defining their pain generator. Finding out exactly where their pain is coming from is the key to treatment, because if you don't have a specific diagnosis, it's difficult to form a treatment plan. So getting a complete evaluation, reviewing newer images, maybe getting diagnostic injections, trying to help pinpoint that pain generator. Once that is accomplished, then you can set a treatment plan. And we do and are able to help a lot of patients that have had prior surgery that continue to have problems down the road. So yes, they potentially could be a surgical candidate.
Yeah, excellent. I agree with you on the point about getting to the root of the problem, the diagnosis, because there's no point in always just medicating a person whenever it's not going to get rid of the problem itself. It's just numbing down the pain.
Absolutely. It's masking the symptoms.
Exactly. Yeah, number 4 is, what works better in your opinion, epidurals or minimally invasive procedures?
Well, epidural injections are typically part of the conservative care realm. It is a procedure, it's an injection, and they certainly have their place. Again, that is part of that, that 2, 3, 4 months of conservative care treatment that people can undergo, whereas a minimally invasive surgical procedure is more of a definitive, literally attacking the patient's pathology. Right. An epidural injection is a steroid that's injected around the epidural nerve root and basically diminishes the inflammation. Whereas a minimally invasive surgical procedure is to correct the cause of the inflammation, which is typically related to a nerve impingement, either by a bone spur, a herniation, maybe even scar tissue. So the surgical would be more of a definitive treatment, whereas the epidural would be more of a trying to resolve the pain without surgery. And certainly people can get a lot of relief from epidurals. They can get months to even years. I've had patients, they get epidural and a year and a half, 2 years go by before the symptoms return.
Excellent. Good to hear. All right, we're jumping on to number 5, and we have 12 questions here for you, okay? Number 5 is, how long after a microdiscectomy does it take for someone to typically go back to their activities of daily living?
Great question. Microdiscectomy means different things to different people. I've had patients undergo microdiscectomy and they come in and they get a 2.5-inch incision. If you're looking at the minimally invasive procedures that we do for just a discectomy, and I can answer from what we do, but again, sure, a microdiscectomy being a little bit more entail of a procedure, depending on the surgeon and who's defining it. But from our perspective, if you were to have a discectomy, patients can resume normal daily activity right after surgery. Matter of fact, people go out to dinner after surgery. When they come to have surgery with us, they stay locally if they travel outside our centers, and they're able to go out to dinner that evening. So they are able to resume normal activities of daily living right after surgery. There are restrictions, certainly. People can return back to work, but it would depend on their job description, right, whether they have a manual job, whether they have a blue collar, whether they're at a desk. So those that have manual jobs, again, it would depend on how manual it is. I mean, how much weight do they carry or lift? That would certainly have a say in when they could return back to work. But people that have a desk job, a lot of times people can just return just a few days after surgery. Because if you think about it, So if you have a minimally invasive procedure, a discectomy that we perform, people are home, right? So they can take a week off. But what are they going to do at home? They're gonna get on their computer. They're gonna eat lunch. They're gonna sit down. They're gonna watch TV. What are you gonna do at work? Well, you're gonna sit down. You're gonna get on your computer. You're gonna stand. You're gonna eat lunch. So you're not really doing anything different than you would be at home from work. So, you know, blue collar desk job, return just a matter of days. Labor may take a little bit longer.
Okay, we're jumping on to number 6. Would you recommend trying conservative treatments, or is it better to jump right into surgery as soon as possible? Well, I think you already answered that one.
Yes.
Right, so we'll go ahead and skip that one. Number 7, what are your thoughts on stem cell injections for disc herniations and sciatica? And do you offer any of those at your facility?
Yes, we do. We do stem cell injections. A lot of people looking at stem cells as the buzzword, the keyword. Everyone's getting stem cells. That's, you know, the key to life. It's better than sliced bread. But honestly, when you're looking at treating patients with back issues and you're looking at stem cell treatments, there's really a very small criteria or a group of individuals that would benefit from stem cells when you're looking at the spine in particular. When we are dealing with a patient and looking to do stem cell injections, the patient has to fit a very limited box. They have to fit in this box. And basically, patients have to have axial back pain, no radicular pain, which means no sciatica. The patient has to have typically 1, maybe 2 levels of degenerative disc. Beyond, if they get 4 or 5 discs that are degenerative, probably not the best candidate. People that have an annular tear is good. If they got a tear of the disc, an annular tear is basically a compromise of the outer part of the disc where the jelly material, liquid material inside the disc wants to leak out, and it accumulates right around the outer part of the disc, and they call that a tear. Those benefit from stem cell injections. And one of the other key points is that the height of the disc is very important. Normal disc height is better. If it's severely degenerative or the disc is very narrowed, the ability for those stem cells to actually work is minimal. So we limit patients with the disc height. It's got to be greater than 50% of normal.
Okay.
So if it's less than 50% the disc height, stem cells typically aren't going to work, and it's not going to benefit the patient. But again, truly, it's just for patients with a discogenic back pain. The pain related to their back is related strictly to the disc. Stem cells have been shown to be beneficial in those cases.
Okay. Excellent. Thanks for that answer there. We're moving on to the next question. Somebody that doesn't have back pain but has sciatica-like symptoms going down the leg, what can they do? Or what can you do in that case?
So, you know, a lot of people come in and they'll say, doctor, I got a pain down my leg. And they don't, it's kind of hard for them to conceptualize that it's actually coming from their back.
Right.
What I explain to patients is people get a referred pain. It's down the nerve root. So when you pinch the nerve in your lower back, the pain travels down that nerve, which goes in the buttocks, down the thigh, and the calf. And that's a referred pain. So people complain of pain related to the nerve impingement, but may not have any issues with their lower back. And that can be normal. In which case, if they do have sciatica related to a disc issue or a nerve impingement from a bone spur, you want to try the conservative treatment, try to resolve it without surgery. But again, once it goes beyond that point, or the pain is excruciating, it's unbearable, it's really limiting their daily activities, then surgical intervention may be the answer.
Okay, excellent. Excellent. The next question is, what have you seen to be the best treatment for herniated discs and sciatica? In your opinion, what's the best treatment? If somebody fails conservative treatment, what would be the next one?
So for a herniated disc, so typically if they've got a herniated disc, they're still symptomatic related to that disc. I think probably the best approach would be probably just a simple discectomy.
Okay.
Just removing part of that disc that's up against that nerve or up against the canal to relieve the pressure on the nerve or the cord or the thecal sac. I think that would be the simplest and easiest and best approach from a surgical perspective. There's also other options available, especially if you've got somebody with a cervical herniation.
Okay.
And if it's very, very central herniation rather than more to the right or left. If it's a central herniation and you're compressing the cord in the neck region, a lot of times an anterior discectomy fusion or a disc replacement may be an option, because when the herniation is central, it's very difficult to get to that herniation from a posterior approach.
So you have to go through the front, huh?
Correct. When you do a disc replacement or fusion, it's from the front. Most of the surgeries that we do in the cervical spine are from the back of the neck. So we remove impingements, herniations, lateral that are pinching a nerve. We can simply just do what we call a discectomy, but it's a foraminotomy. Basically what we're doing is opening up the canal, the foraminal canal, where the nerve exits. Right. So we do that from a posterior approach. It's very simple. It's a lot less invasive than a fusion or a prosthetic disc placement. So again, but if it's central, it's more of an anterior approach, fusion versus disc replacement.
Okay. All right. Good information there. All right. Once a disc herniates, is this a permanent injury? Will that person ever have the disc be the same as it was before?
And the answer to that is typically no. When people have a herniated disc, basically there is a compromise to the annulus fibrosus, which is the outer part of the disc, so it's been compromised, and that gives the ability for the disc to herniate. I always like to tell patients, like squishing a donut, a jelly donut. You squish the jelly donut, the jelly comes out. There's a compromise to the outer part of the donut. So will it ever go back to normal? Your disc is always going to be abnormal. It's not going to be perfectly healthy and normal. Okay. You can still treat that patient. You can conservative care, potentially surgery. I've seen patients that have a huge herniated disc, and 6-9 months later, an MRI scan, the herniation has been reabsorbed by the body, which is fantastic. But your disc will always remain abnormal at that point.
Okay. Good to know. I get a lot of people asking me that question, and some people have mentioned the reabsorption as well. So, yes. I mean, it's something that I guess you never know if it's going to go in by itself or not.
And that's a great point, because a lot of people have known somebody or been told, hey, it can get reabsorbed. And so people wait months and months waiting for it to get reabsorbed, but a lot of times it may not. Yeah. In which case, at what point does a patient say, okay, I've waited long enough, I'm still having a problem, let's go ahead and take care of it. And only the patient can make that determination. But I have seen discs reabsorb, which is great for the patient. Okay.
And the last question we got for you today is, what sets the Laser Spine Institute apart from other competitors in what you do?
Well, I think it's basically our patient-centric approach. We have a very holistic, very patient-centered evaluation process. When patients come in, I like to look at it as an experience, not only for the patient, but for the caregiver. People will come in with family members or friends that are with them, and it's got to be an experience for the whole family. It's not, we're not focusing on the patient, but we're also focusing on the caregivers. So getting down to the bottom of the patient's medical condition, the source of their problem, finding out, getting a detailed evaluation, making a clinical diagnosis, and then forming a treatment plan, is what we focus on. We focus on the patient. We want to be a very patient-centric approach. The other thing is, a lot of times we do things that other facilities won't do, or we do things differently. When patients come to us, a lot of them have been told that they need a fusion. And the patients are looking for options other than fusions. And a vast majority of the surgeries we do are non-fusion cases. So where another surgeon may recommend a fusion, we would recommend just a simple decompression. Again, a 45-minute outpatient surgical procedure. So that separates us from a lot of our competitors.
Gotcha. And I know a lot of people fly in from other places to see you guys. Where do you have locations in the United States?
We have our centers, and our main one here is in Tampa, which is where I'm located. We have a center in Scottsdale, Arizona, Philadelphia, Pennsylvania, Oklahoma City, Oklahoma, St. Louis, Missouri, Cleveland, and Cincinnati, Ohio.
Oh, good. So you have several states around the United States. Any international or any plans for international?
Not yet, but we're planning global domination very soon.
Excellent. People need it. People need it. So that's all we have to ask for you today, Dr. Perry, and we appreciate you being on the show today. And this is going to be seen by many, many people. So hopefully people in the United States can give you guys a call, help you out, or you can help them out as well. And what we've done is we've set up a link for people to request more information from you guys, from the Laser Spine Institute. And that link is going to be on the screen. It's going to be painfreeinstitute.net/LSI, as in Laser Spine Institute. Again, thank you for your time. Anything else you want to say, Doc?
No, I appreciate the time and allowing me to kind of explain a lot of things about what we do. I think a lot of times people have a misconception about the actual procedures that we do perform, and getting on venues like this allows me the ability to kind of lay the foundation of exactly what potentially procedures we can perform and how we can help patients throughout the world. Thank you.
Excellent, excellent. Well, thank you for your time, and we appreciate you, and we'll catch you again some other time. All right, Doc?
All right, Dr. G, thank you.
You're welcome. Have a good day.
You too.